COVID-19 pandemic. The ongoing global pandemic of coronavirus disease 2019, COVID-19, is caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. The novel virus was identified in Wuhan, China, in December 2019. A lockdown in Wuhan and other cities in Hubei province failed to contain the outbreak, and it spread to other parts of mainland China and around the world. The World Health Organization, WHO, declared the outbreak a public health emergency of international concern on January 30, 2020, and a pandemic on March 11, 2020. Since 2021, variants of the virus have emerged or become dominant in many countries, with the Delta, Alpha, and Beta variants being the most virulent. As of August 6, 2021, more than 200 million cases have been confirmed, with more than 4.26 million confirmed deaths attributed to COVID-19, making it one of the deadliest pandemics in history. COVID-19 symptoms range from unnoticeable to life-threatening. Severe illness is more likely in elderly COVID-19 patients, as well as those who have certain underlying medical conditions. COVID-19 transmits when people breathe in air contaminated by droplets and small airborne particles. The risk of breathing these in is highest when people are in close proximity, but they can be inhaled over longer distances, particularly indoors. Transmission can also occur if splashed or sprayed with contaminated fluids, in the eyes, nose, or mouth, and, rarely, via contaminated surfaces. People remain contagious for up to 20 days, and can spread the virus even if they do not develop any symptoms. Recommended preventive measures include social distancing, wearing face masks in public, ventilation and air filtering, hand washing, covering one's mouth when sneezing or coughing, disinfecting surfaces, and monitoring and self-isolation for people exposed or symptomatic. Several vaccines have been distributed in most countries since December 2020. Current treatments focus on addressing symptoms, but work is underway to develop medications that inhibit the virus. Authorities worldwide have responded by implementing travel restrictions, lockdowns and quarantines, workplace hazard controls, and business closures. There are also efforts to increase testing capacity and trace contacts of the infected. The pandemic has resulted in severe global, social and economic disruption, including the largest global recession since the Great Depression of the 1930s. It has led to widespread supply shortages exacerbated by panic buying, agricultural disruption, and food shortages. However, it has also caused temporary decreases in emissions of pollutants and greenhouse gases. Numerous educational institutions and public areas have been partially or fully closed, and many events have been cancelled or postponed. Misinformation has circulated through social media and mass media, and political tensions have been exacerbated. The pandemic has raised issues of racial and geographic discrimination, health equity, wealth inequality, and the balance between public health imperatives and individual rights. Without naming. The pandemic is known by several names. It is often referred to as its colloquial name, the coronavirus pandemic, despite the existence of other human coronaviruses that have caused epidemics and outbreaks, e.g. SARS. Before it was declared a pandemic, it was known as the coronavirus outbreak and Wuhan coronavirus outbreak. During the initial outbreak in Wuhan, the virus and disease were commonly referred to as coronavirus and Wuhan coronavirus, with the disease sometimes called Wuhan pneumonia. In January 2020, the WHO recommended 2019 nCoV and 2019 nCoV acute respiratory disease as interim names for the virus and disease per 2015 guidance and international guidelines against using geographical locations, e.g. Wuhan, China, animal species, or groups of people in disease and virus names in part to prevent social stigma. The official names COVID-19 and SARS-CoV-2 were issued by the WHO on February 11, 2020. Tedros Adhanom explained, CO for corona, 6 for virus, D for disease and 19 for when the outbreak was first identified, December 31, 2019. The WHO additionally uses the COVID-19 virus and the virus responsible for COVID-19 in public communications. The variants of the virus are also known by several names. Before being given official names by the WHO, they were commonly named after where the variants were found, e.g. Delta variant was known as the Indian variant, and are also known colloquially as variants of concern. At the end of May 2021, the WHO assigned labels to all the variants after introducing a new policy of using Greek letters for variants of concern and variants of interest. About epidemiology. First we will talk about the background of coronavirus. Although the exact origin of the virus is still unknown, the first outbreak started in Wuhan, Hubei, China in November 2019. Many early cases of COVID-19 were linked to people who had visited the Huanan seafood wholesale market in Wuhan, but it is possible that human-to-human transmission was already happening before this. On February 11, 2020, the World Health Organization, WHO, named the disease COVID-19, which is short for Coronavirus Disease 2019. The virus that caused the outbreak is known as severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, a newly discovered virus closely related to bat coronaviruses, pangolin coronaviruses, and SARS-CoV. The current scientific consensus is that the virus is most likely of zoonotic origin, from bats or another closely related mammal. Despite this, the subject has generated a significant amount of speculation and conspiracy theories, which were amplified by rapidly growing online echo chambers. Global geopolitical divisions, notably between the United States and China, have been heightened because of this issue. The earliest known person with symptoms was later discovered to have fallen ill on December 1, 2019, and that person did not have visible connections with the later wet market cluster. However, an earlier case of infection could have occurred on November 17. Of the early cluster of cases reported that month, 2/3 were found to have a link with the market. Molecular clock analysis suggests that the index case is likely to have been infected with the virus between mid-October and mid-November 2019. Statistics of cases of COVID-19 infection. Official case counts refer to the number of people who have been tested for COVID-19 and whose test has been confirmed positive according to official protocols. Many countries, early on, had official policies to not test those with only mild symptoms. An analysis of the early phase of the outbreak up to January 23 estimated 86% of COVID-19 infections had not been detected, and that these undocumented infections were the source for 79% of documented cases. Several other studies, using a variety of methods, have estimated that numbers of infections in many countries are likely to be considerably greater than the reported cases. On April 9, 2020, preliminary results found that 15% of people tested in Ganjult, the center of a major infection cluster in Germany, tested positive for antibodies. Screening for COVID-19 in pregnant women in New York City, and blood donors in the Netherlands, has also found rates of positive antibody tests that may indicate more infections than reported. Seroprevalence-based estimates are conservative as some studies show that persons with mild symptoms do not have detectable antibodies. Some results, such as the Ganjult study, have received substantial press coverage without first passing through peer review. An analysis in early 2020 of cases by age in China indicated that a relatively low proportion of cases occurred in individuals under 20. It was not clear whether this was because young people were less likely to be infected, or less likely to develop serious symptoms and seek medical attention and be tested. A retrospective cohort study in China found that children and adults were just as likely to be infected. Initial estimates of the basic reproduction number, R0, for COVID-19 in January were between 1.4 and 2.5, but a subsequent analysis concluded that it may be about 5.7, with a 95% confidence interval of 3.8 to 8.9. R0 can vary across populations and is not to be confused with the effective reproduction number, commonly just called R, which takes into account effects such as social distancing and herd immunity. By mid-May 2020, the effective R was close to or below 1.0 in many countries, meaning the spread of the disease in these areas at that time was stable or decreasing. Statistics of deaths due to COVID-19. Official deaths from COVID-19 generally refer to people who died after testing positive according to protocols. These counts may ignore deaths of people who die without having been tested. Conversely, deaths of people who had underlying conditions may lead to overcounting. Comparisons of statistics for deaths for all causes versus the seasonal average indicate excess mortality in many countries. This may include deaths due to strained healthcare systems and bans on elective surgery. The first confirmed death was in Wuhan on January 9, 2020. Nevertheless, the first reported death outside of China occurred on February 1, 2020 in the Philippines, and the first reported death outside Asia was in the United States on February 6, 2020. More than 95% of the people who contract COVID-19 recover. Otherwise, the time between symptoms onset and death usually ranges from 6 to 41 days, typically about 14 days. As of August 6, 2021, more than 4.26 million deaths have been attributed to COVID-19. People at the greatest risk of mortality from COVID-19 tend to be those with underlying conditions, such as those with a weakened immune system, serious heart or lung problems, severe obesity, or the elderly, including individuals aged 65 years or older. Multiple measures are used to quantify mortality. These numbers vary by region and over time, influenced by testing volume, healthcare system quality, treatment options, government response, time since the initial outbreak, and population characteristics, such as age, sex, and overall health. Countries like Belgium include deaths from suspected cases of COVID-19, regardless of whether the person was tested, resulting in higher numbers compared to countries that include only test-confirmed cases. The death-to-case ratio reflects the number of deaths attributed to COVID-19 divided by the number of diagnosed cases within a given time interval. Based on Johns Hopkins University statistics, the global death-to-case ratio is 2.12%, 4,267,212 deaths for 200,875,158 cases, as of August 6, 2021. The number varies by region. The official death counts have been criticized for underreporting the actual death toll, because comparisons of death rates before and during the pandemic show an increase in deaths that is not explained by COVID-19 deaths alone. Using such data, estimates of the true number of deaths from COVID-19 worldwide have included a range from 7 to 13 million by The Economist, as well as over 9 million by the Institute for Health Metrics and Evaluation. Reporting. On March 24, 2020, the Centers for Disease Control and Prevention, CDC, of the United States, indicated the WHO had provided two codes for COVID-19, U07.1 when confirmed by laboratory testing and U07.2 for clinically or epidemiological diagnosis where laboratory confirmation is inconclusive or not available. The CDC noted that because laboratory test results are not typically reported on death certificates in the U.S., the National Center for Health Statistics, NCHS, is not planning to implement U07.2 for mortality statistics and that U07.1 would be used if the death certificate reports terms such as probable COVID-19 or likely COVID-19. The CDC also noted it is not likely that NCHS will follow up on these cases, and while the underlying cause depends upon what and where conditions are reported on the death certificate, the rules for coding and selection of the cause of death are expected to result in COVID-19 being the underlying cause more often than not. On April 16, 2020, the WHO, in its formal publication of the two codes, U07.1 and U07.2, recognized that in many countries detail as to the laboratory confirmation will not be reported and recommended, for mortality purposes only, to code COVID-19 provisionally to code U07.1 unless it is stated as probable or suspected. It was also noted that the WHO does not distinguish between infection by SARS-CoV-2 and COVID-19. Infection fatality ratio, IFR. A crucial metric in assessing the severity of a disease is the infection fatality ratio, IFR, which is the cumulative number of deaths attributed to the disease divided by the cumulative number of infected individuals, including asymptomatic and undiagnosed infections, as measured or estimated as of a specific date. Epidemiologists frequently refer to this metric as the infection fatality rate to clarify that it is expressed in percentage points, not as a decimal. Other published studies refer to this metric as the infection fatality risk. In November 2020, a review article in Nature reported estimates of population-weighted IFRs for a number of countries, excluding deaths in elderly care facilities, and found a median range of 0.24% to 1.49%. In December 2020, a systematic review and meta-analysis published in the European Journal of Epidemiology estimated that population-weighted IFR was 0.5% to 1% in some countries, France, Netherlands, New Zealand, and Portugal, 1% to 2% in several other countries, Australia, England, Lithuania, and Spain, and about 2.5% in Italy. These estimates included fatalities in elderly care facilities. This study also found that most of the differences in IFR across locations reflected corresponding differences in the age composition of the population and the age-specific pattern of infection rates, due to very low IFRs for children and younger adults, example 0.002% at age 10 and 0.01% at age 25, and progressively higher IFRs for older adults, 0.4% at age 55, 1.4% at age 65, 4.6% at age 75, and 15% at age 85. These results were also highlighted in a December 2020 report issued by the World Health Organization. IFR estimate per age group. An analysis of those IFR rates indicates that COVID-19 is hazardous not only for the elderly but also for middle-aged adults, for whom a fatal COVID-19 infection is 2 orders of magnitude more likely than the annualized risk of a fatal automobile accident and far more dangerous than seasonal influenza.